you, Athol. It's an honor to be here. Thank you for that very generous introduction. And of course, Professor Antonio, for the very warm hospitality and the invitation to speak, as well as the invitation of the whole organizing committee. So I will talk for 20, no more hopefully than 25 minutes on what's been going on in AI and interstitial lung disease for the last few years. These are my disclosures, and the one I think that's most relevant is my role with Bronomics, and I'm going to show some of the data we have generated, but I'm hopeful I'll be able to show you a very broad array of everything that's been going on in this space for the past few years. So the first thing to say is that we already have fairly good ways of determining a risk of a patient's likelihood of progressing in interstitial lung disease. And the UIP status, usual interstitial pneumonia status on CT, which is a corollary for what we know pathologically from older biopsy studies, is established regardless of the type of interstitial lung disease. So in rheumatoid arthritis, in hypersensitivity pneumonitis, in scleroderma, in a number of ILDs, we know that this pattern, as defined by a radiologist, is able to predict with some certainty the likelihood of a poor outcome for a patient. But the problem we have is that this cardinal feature on a CT scan is not always readily agreed upon by our radiologists. And of course, I am able to say this because I'm married to a radiologist, so I'm not here to give the radiologist a hard time. But let's just say that when you look at this slide, you see that not only do they disagree on whether there is UIP or there is honeycombing or there is traction bronchiectasis, but as they get older, they disagree even less. So I'm not sure what I will take from that other than to say that it doesn't appear to be the best feature in terms of reproducibility. And we know that in work that's gone on over the past few years, and Athol has pioneered much of this work with Simon Walsh, that actually AI has helped us improve our ability to identify UIP on a CT scan. This is one of Simon and Athol's earliest studies in the Lancet Respiratory, I think it was, or maybe even the Lancet, Athol. Lancet Respiratory, showing that when you look at radiologists' ability to define UIP and you compare that to the SOPHIA algorithm, the SOPHIA algorithm appears to outperform visual evaluation. And actually, when you combine the two, you're able to improve your sensitivity and specificity for identifying UIP even further. So we don't consider AI to necessarily be there to replace the radiologist. Rather, it is probably to enhance our ability to identify the patterns that we know are important. More recently, excellent work from Steve Humphries and from Jonathan Chung showing that, once again, these algorithms, whether they are DTA-based, whether they are InBio-based, whether they're SOPHIA-based, are able to identify UIP with a good degree of sensitivity, and that is able to identify patients at high risk of poor outcomes. So we're pretty good now at UIP classification, and we've improved upon it certainly with our tools. But I will put to you that what we have thought was important all along may not actually be that important. And there may be emerging data, and there's been 5 very good studies over the past year that have shown that disease extent outperforms UIP. And I'll show you a couple of these. This is a paper in the Annals from last year, which shows that regardless of whether you have alternative diagnosis in the top left or definite UIP in the bottom right, your extent of disease is by far the most prognostic, regardless of how certain you are that there is UIP or not. And the authors go on to state that the differences in survival are driven by the amount of disease and not necessarily by the classification of UIP. This is another paper using QLF, quantitative lung fibrosis. And once again, you can see on the left-hand side, you have patients who have a UIP-like pattern. And on the right-hand side, you can see those with a high disease extent. And the lines on the left overlap, which shows that, again, UIP maybe doesn't discriminate so well. But on the right, our quantitative lung fibrosis score, our ability to identify disease extent using quantitative CT tools, is more discriminatory, showing us again that perhaps UIP is not the most important feature. And there have been another 2 papers I won't go into, one in radiology from the CARE PF Canadian registry showing the same, and Steve Humphries' DTA data from National Jewish. So 4 studies in a year showing us that disease extent outperforms UIP. Athol, Joe Jacobs, and others have spent some time thinking about the vasculature, and many of us believe the vasculature plays an important role in perhaps driving fibrosis, but certainly in being able to provide us with prognostic signals. And whether you look at pulmonary vessel volume or vessel-related structures in a number of disease areas, we've shown that this is prognostic and is able to identify patients at risk of mortality and lung function decline. And this is some work we published with Anand Devraj, my colleague at the Brompton, as the first author, where we took a completed AstraZeneca data set and we used the Brainomics E-Lung weighted reticular vascular score. So that, just to orientate you, that incorporates all of the vascular abnormalities, vascular structures, and fibrosis in the periphery of the lung. So it's a peripheral fibrosis score, essentially. And if you have a score of 15% or above, you can see on the left-hand side, patients lose lung function very quickly. So over the course of 52 weeks, these patients are all losing lung function. Whereas on the right-hand side, if you have a WRVS of less than 10%, patients remain stable. And this allows us to start thinking about how we can consider this imaging biomarker when we want to predict and prognosticate for an individual patient. And you can see these are quite small numbers, 60 patients, 50 in one arm, 15 in the other. And even with small numbers, you're able to show significant separation, albeit with fairly wide confidence intervals. This is a study that we, again, using the E-Lung WRVS score, where we compared the ability for radiologists to define progression at a year, lung function progression at a year, and the quantitative CT tool at 1 year. So we took 2 time points, baseline and 12 months. We looked for changes between the two, and then we looked at the discriminatory ability to define mortality thereafter. And you can see actually all 3 do fairly well. Radiologists telling us that there's progression have a hazard ratio of 5.5. Patients losing 10% of FVC have a hazard ratio of 6. And a rise in this imaging biomarker, a hazard ratio of 6.4. So really very similar outcomes and ability to discriminate. So this is a study that we put together and presented earlier this year at the ATS, where we wanted to go back and answer this question about UIP versus disease extent. And we thought the best way to do this would be to take a cohort of patients with non-IPF fibrotic ILD, around 300 patients, consecutive patients, and we scored them for UIP status, so scored by Anand Devraj as either definite or probable UIP, that was considered UIP, or indeterminate and alternative diagnosis, and that was considered not UIP. We asked 2 radiologists to score the scans visually for extent of disease, and we looked to see which of these 3 was the most sensitive to outcomes. Was it UIP? Was it as scored by an expert radiologist? Was it the amount of fibrosis as scored by 2 expert radiologists? Or was it the weighted reticular vascular score, the E-Lung metric? And what you can see on the top here is when you look at mortality, the strongest predictor of mortality is the weighted reticular vascular score. Not far behind that is the extent of fibrosis as defined by radiologists, but UIP starts to fall some way behind, again, challenging some of this dogma that we've applied previously. And for the same 3 parameters, when you look at likelihood of future lung function decline, again, you look at the WRVS, which outperforms extent of fibrosis, which outperforms UIP. So you have our 2 important outcome measures, survival and lung function decline, both telling us in the same direction that disease extent is an important measure here, and that our ability to do this quantitatively using an algorithm outperforms that which we can use by eye, which I think is not that surprising. Here you can see on the left-hand side whether patients had a high WRVS score versus a low WRVS score. You see a hazard ratio of 4.5. So this was 15% being high. We did it in tertile, so high versus low or medium, and again, a very clear distinction. But on the right-hand side, UIP versus non-UIP, again, I'm telling you the same thing again, overlapping lines, just meeting significance. And I think this is quite interesting because the red lines at the bottom are patients who have a high WRVS, and either UIP or not UIP. So at the bottom red line, these are patients who are doing very badly. It's again extent of disease as measured using the weighted reticular vascular score, which is driving the outcome signal here. And possibly what we're actually measuring is almost an extent of UIP, because you're measuring peripherality of disease. It's fibrosis in the periphery. And what I think we have been considering over the years is that UIP is important, but maybe the extent of UIP is more important. So we're turning something from a binary outcome into a continuous outcome, and that, I think, is why we're seeing something much more powerful. We know that lung function is important. We use lung function in our registrational studies. This is the in-build data. We've recently seen positive data in the Fibronis study showing that FVC remains an important endpoint. And although some of us had worried that FVC would lose its ability to do so as we added in new therapies as standard of care, for whatever reason, that has not been shown to be the case. And so lung function is an important measure that we continue to use. But in that same in-build study, 3 expert radiologists were given CT scans from the in-build imaging sub-study. So half of this, so for those that are not orientated, the in-build study is nintedanib in progressive pulmonary fibrosis, or PF-ILD. And half of the 600-odd patients that were in that study were entered into an imaging sub-study, and they had a CT scan at baseline, 6 months and 12 months. This has been analysed subsequently, and Athol was involved in this work, and the 3 radiologists, I think, who read this were Simon Walsh, Anand Devraj, and Nicholas Vetzelati, and they were given the scans and were not given any information about treatment indication, of course, or which scans were baseline and which scans were follow-up. And what you can see as a summary is that even the expert radiologists were unable to find a treatment effect when they were given the scans and they tried to score them. There was a subtle signal to a reduction in how much ground glass there was in the nintedanib group. This was sort of marginal, but they were unable to define a treatment effect, which maybe dampened down enthusiasm for what CT can do for us when we look at clinical trials. But what we have done subsequently, this is data that's currently in submission for publication, going through some painful revisions, is we took the imaging, the in-build imaging sub-study, and Brainomix and QLF were blinded to outcomes and were given the scans, had to produce biomarker outputs, and the outputs were given back to BI to evaluate the data. And the intention here was to see whether quantitative CT was able to identify treatment effect in a positive clinical trial. So on the left-hand side is the native CT scans, as you can see them here. Here is the UCLA QILD QLF tool. This is Jonathan Golden and Grace Kim's work. And on the right-hand side is the eLung, which is the work that myself and Anand Devraj have been working on. And the yellow pixelated is ground glass, the red is the reticular vascular, QILD is essentially an accumulation of all the interstitial lung disease, which is ground glass, fibrosis, honeycombing. The total disease extent for eLung is a combination of all of the fibrosis, the reticular vascular scores, and the ground glass. So it's a totality of all the extent of disease on a scan. And so the first data slide here is we show that in half the number of patients, and at the week 24 point and also at the week 52 point, the UCLA QILD tool is able to identify a treatment effect comparing nintedanib with placebo, in line with what we saw in the lung function and not what we saw using visual evaluation. And the numbers are almost identical for the Brainomix eLung evaluation. And I think this is very positive. The fact that we are having 2 different algorithms, 2 different platforms telling us fairly similar information gives us as a community the confidence that this technology or these technologies have a place for us as we move forward. The next thing we looked at was, could you prognosticate from a baseline CT scan in the placebo group? So in the patients who were given just the placebo, are there features on a scan which could identify risk of future lung function decline and risk of future mortality? And so this is the, at the top is the QILD, then is eLung disease extent, then is QLF, and then is WRVS. And the way you look at this data is for every unit that goes up for any of these parameters, that is the amount of FVC loss. So for a unit increase in QILD, that patient would be predicted to lose 20 mils or 19.8 mils. And for every unit of WRVS that goes up at the bottom, that patient would lose 29 mils over the course, as a rate of decline over the course of 52 weeks. So now we're able to not just predict the likelihood of somebody losing lung function, but we're able to sharpen that further and to some degree of accuracy, predict the amount of lung function in mils that patient might lose over the subsequent 52 weeks. This is similar prognostication data in the placebo group. We cut each of these data points at the median. And again, you can see that you look at above and below the median, patients are losing essentially over the course of 52 weeks, 139 versus 233, 160 versus 230. So again, sharply discriminating between somebody who's at risk of poor progression, poor outcomes and accelerated progression, or IPF-like progression. This again is similar data, so I'm showing you the time to absolute decline using these imaging biomarkers at baseline. So again, predicting likelihood of FVC decline of 10% or death by cutting these biomarkers at the median. And again, I think what is really nice to see here is you're seeing two different algorithms, two different technologies showing us almost identical data, hazard ratio of 1.7 on the left, 2.1 on the right. I don't think this tells us that one is superior to the other. It tells us that both are giving us important signals. And again, identical data using the QLF on the left or the WRVS on the right, both show a hazard ratio of 2.9 for death over the course of the whole trial. So this is out to 900 days. So you're seeing not just a short-term prediction of lung function decline, you're seeing a durable prediction of mortality out to 3 years. So this is where I think the future may take us. This is some work that we've been doing at the Brompton, and we'll be looking to validate this, is using these imaging biomarkers to identify subtle interstitial lung abnormalities, subclinical changes, and then quantify that change over time. And we know that our radiologists are unable to accurately identify changes like we're seeing here of just over 3%. But we also know that 3% is the minimum clinically important difference of the WRVS. So this is a patient who is progressing. And although our radiologist might say the reticulation is a bit coarser, I think there's a bit more disease, that doesn't help us when we're trying to make a treatment decision for a patient who has no symptoms. And so we need to start thinking about how we can integrate this kind of technology into our clinical decision making. I've got, I think, a couple more slides just to talk about the pitfalls and the challenges. So I think I've shown you lots of attractive data, lots of fancy hazard ratios and Kaplan-Meier curves, but there are barriers to this kind of technology. We need to achieve regulatory clearances, and these are some of the companies who've managed to do so in the FDA and the European CE marking. But clearances are an important first step. We need to understand how you can compare two CT scans that have come from two different scanners, two different kernels, two different acquisition subtypes, and be able to harmonize that data so that you can achieve useful information. And even our radiologists will often say, well, that's too sharp, that's too hard, repeat the imaging. And so how do we use technology to start to harmonize some of that imaging? I think there's been a perception amongst our community that the lack of comparator data is hampering our ability to decide which is the horse to back. I don't think we need to back a horse. I think we need to back the technology and the concept, because however we get there, I think it's important we advance the field. It's important we work out who's paying for this technology. So if you have a piece of equipment which is going to improve your ability to look after a patient, is it the hospital? Is it the payer? Is it the insurance company? And how we can build that evidence to do so. And I think there is a sense that radiologists certainly and physicians want explainable AI. So if I look at a scan and I'm given an output of numbers, I want to be able to look at that scan and understand what those numbers mean and how they have got to a page. So I think that concept of having overlays giving you an output allows you to make sensible decisions. I think the future, hopefully, is going to involve us moving to using this type of technology for clinical trials. We need to go through processes where the regulator accepts these new biomarkers for a primary endpoint. I think that is some way off, but is certainly something that I think a number of pharma companies and device manufacturers are looking at. How do we integrate this type of technology into our routine healthcare? How do we start to ask our radiologists for a quantitative CT read so that we're not guessing as to whether a patient really has progressed or not, or is likely to progress or not? Can we streamline patients by predicting those at risk of bad outcomes by putting them into transplant programs earlier, or earlier treatments for ILA, for example? How do we achieve a different paradigm before the horse has already bolted? Where do we start the treatments earlier, and how do we deliver that? We need to think about networking our solutions, bringing hospital groups together so that you can have scans compared in referral networks appropriately. And I think the concept of using ILA evaluation using this technology is the way forward. So thank you.